What's up, gut gurus? My name's Kirk Russ. I'm a gastroenterologist with UAB's Division of Gastroenterology and Hepatology. Today, we're going to briefly review inpatient management of patients with IBD. Now, this is a common question I get from trainees, and fortunately, the answer is not all that complicated. So, I hope you find this virtual chalk talk helpful. So, before we get into inpatient management, let's take a step back and talk about what is inflammatory bowel disease. Well, IBD is a term for two conditions, Crohn's disease and ulcerative colitis, that are characterized by chronic inflammation of the GI tract. And that prolonged inflammation can result in damage to the GI tract. Ulcerative colitis, which you can see on the right here, is primarily a mucosal inflammation that always involves the rectum and extends to varying degrees proximally. In contrast, Crohn's disease, which you can see here on the left, is characterized by transmural or full thickness inflammation that can occur anywhere mouth to anus, but has a predilection for the small bowel as well as the colon, and often has skip areas of inflammation right next to uninflamed segments of bowel. Now, the pathogenesis of IBD is still incompletely understood, but at present, our best understanding is that IBD develops due to an inappropriate immune response to environmental triggers, primarily intestinal microbes and the diet, in genetically susceptible individuals. So it's an interplay of all three of these areas. So when do patients with IBD need to be in the hospital? Well, in ulcerative colitis, hospitalization should be considered in patients with severe symptoms, more specifically more than 6 to 10 bowel movements a day, plus signs of systemic toxicity like fever, tachycardia, anemia, particularly anemia requiring blood transfusion, and severely elevated blood inflammatory markers like ESR and CRP. What about for Crohn's disease? Well, in Crohn's disease, reasons for hospitalization also include systemic toxicity, just like in UC, but also complications of the disease, things like a bowel obstruction from a fibrotic stricture, or penetrating complications like bowel perforations or abscesses, or simply a disease flare that's just not responding to outpatient therapy. All right, so the decision's been made to admit a patient with IBD to the hospital. What do we do now? Well, of course, we start with a history and physical. So in our history, we want to find out why the patient's coming into the hospital, and we also want to get a good history of their disease. What prior treatments have they had? What prior surgeries have they had, etc. Now, on a physical exam, the main things we're looking for are signs of peritonitis, like rebound tenderness or guarding, as well as abdominal distension, which could signify a megacolon in a patient with ulcerative colitis, or potentially a bowel obstruction in a patient with Crohn's disease. You also want to feel around for any fullness or mass, which we can commonly see in Crohn's disease in the right lower quadrant in an area of inflamed ileum. So after we've done our H&P, we want to obtain basic labs, things like CBC, comprehensive metabolic panel, blood inflammatory markers, ESR and CRP. But we also want to obtain stool tests, in particular C. difficile testing, because up to 30% of patients with IBD that are hospitalized are positive for C. diff. And so it's important to treat this along with their IBD. We also want to obtain stool inflammatory markers like calprotectin or lactoferrin, as these can be helpful as we follow our response to treatment going forward. So after we've gotten our initial lab work, we should consider imaging. In ulcerative colitis patients, this can be as simple as a plain abdominal film, which you can see here in the image on the left. And you're doing this to evaluate for megacolon and perforation, which are dreaded complications of ulcerative colitis. And what you see here is an example of a megacolon, a very dilated, kind of featureless colon in that x-ray picture. Now, in Crohn's disease, if they haven't had recent imaging, we should consider cross-sectional imaging with either a CT interrography or an MR interrography. And this will help us define inflammatory activity as well as complications of Crohn's disease like strictures, fistulas, and abscesses. And what you see here in the image on the right here is an example of a stricture where the arrow is pointing, and then the bowel upstream of that is all dilated with air fluid levels consistent with the bowel obstruction. All right, so we've done our initial H&P, our initial workup with labs and imaging. Now, how do we treat these patients? So initially, we're really just providing supportive care. So you want to correct electrolyte abnormalities, correct volume depletion with IV fluids. If they've got sepsis, you want to give them IV antibiotics. If there's no sepsis, it's okay to start IV steroids, and typically methylprednisolone 60 milligrams a day is sufficient. Now, this can be tricky because IBD flares can mimic sepsis. So if you're not sure if there's an active underlying infection, it's okay to hold off on steroids. This is not a decision that has to be made overnight. Now, next, you want to consult your friendly gastroenterologist and or colorectal surgeon. As gastroenterologists, we often help guide the primary team on when a surgery consult is needed, so it's okay to start with us. The patient may need things like inpatient biologic treatment, nutritional support with TPN, they could need surgery, or they may simply need a steroid taper and close out patient follow-up. But we can help guide those decisions, so give us a call early on. And lastly, and this is my biggest soapbox, do not forget about DVT prophylaxis. Yes, these patients are often experiencing rectal bleeding, but this is chronic and very unlikely to cause life-threatening bleeding. Because of their active IBD, they are very high risk for DVT and PE and should always receive prophylactic heparin or enoxaparin when hospitalized with a disease flare. So make sure it's ordered, make sure the nurse is giving it, make sure the patient's not refusing it, but don't forget it. All right, well, that about wraps it up. So thank you for your attention. I hope you enjoyed this brief talk on inpatient management of IBD.